I came from a country that about 15% of the people in Brazil, they self-declare they have black skin. About 42% they say, okay, so we are a kind of mix. And about 30% they declare itself as Caucasians, as white-skinned people. So this was the environment that I grew up. So I see miscegenation as a very positive force. When we study genetics, we know that inbreed, when you have sons and relationships only inside your community, this is not bad for genetics. This is not good for genetics. It started to have a lot of genetic problems, and we can see these in specific populations around the world that have this inbreeding going on. That's exactly the opposite in Brazil. We are a melting pot of different cultures, different skin colors. So I think that this is very nice, but we need to be prepared to help our patients with dark skin, with these different problems. And they have a lot of problems actually that in where we can help. So started with the dyschromias. Many patients have different skin colors related to inflammatory diseases. So this is a big problem for people with dark skin. They also have problems with their hair. They lose hairs in different patterns that Caucasians used to do. And of course, we have skin cancer. When we think about skin cancer, we forget that first of all, we have specific situations where dark-skinned people, they work as fair-skinned people. For example, during albinism situations with the albinism, so we have people with the black features on their face, hair, but they have white skin. So they looks like and works like fair-skinned people. The other thing is that we have genetic diseases like Xeroderma pigmentosum, when you have failure in the process to repair your DNA. And when it happens, doesn't matter if you have a dark skin or fair skin, you're going to have skin cancer. The other point is that not all skin cancers, they came from UV radiation. This is an important thing. For example, for squamous cell carcinoma, there are other trigger factors such as trauma, such as surgeries, scars, chronic scars, chronic infections, including chronic infections. So this makes that squamous cell carcinoma, that for the white population affects like 14 to 16% of the skin cancer cases, and the dark skin population is the most important skin cancer. So this is the first thing. Second thing, talking about melanoma. Melanoma is the most aggressive skin cancer, and it can progress in a very bad way in a matter of a few months. What happened in the dark skin population is that they used to have melanoma on the acral areas, on the feet, on the hands, where they don't have a lot of pigmentation. And it takes a while for people to think about this diagnosis. So what we have in the real life is that the time between the start of the lesion until the diagnosis, it's much longer in dark-skinned people than in white people. So when you get the diagnosis, oh, okay, you have melanoma, you already have, the chance that you already have metastases, other problems is much higher. So this is something that we need to be aware. So as I was telling you, I think that photoprotection is something that we need to be worked among dark-skinned people. So it's not because you have dark skin that you are free to use photoprotection. You should use photoprotection and other photoprotection strategies. So like hats, like shirts. So this is one point. The second point is that we have different clinical features in these patients, like melanonychia. When you have a melanonychia in a white-skinned person, it's something that you were really aware and gives a lot of problems. Let's do a biopsy in the nail. We're going to give you a scar. This is the kind of stuff. But when you go to the dark skin, almost all of them have melanoma. So if you have this same kind of approach between the dark skin patients and white skin patients, it's hard to have this balance because, you're going to have to biopsy all nails in dark skin patients. So this is something that we need to be aware. The third point is that, dyschromias, hyperchromias, hypochromias, achromias are much more common among dark skin patients because of the structure of the skin itself. So, and it bothers a lot the patients when you got vitiligo and you have Caucasian skin. Sometimes nobody will notice except your mother. But then when you have a dark skin and you have a small patch of vitiligo, it gives you a lot of problems. So this is something that we need to understand, and we need to be there together with the patients to help him to recover, to do it in the right way, to understand that we need to stand with the patient to help him in the journey. Talking about my point of view as Brazilian, what we should do is that almost all data that we have belongs to the African American patients. So the patients from Africa, their roots from Africa that came to US, or sometimes some data from India. We don't have a lot of data from Brazil, and we should have. So first thing is that we need to understand that there's a lot of information, data that we should look for as dermatologists inside our community, inside our country, inside our cities, to learn the best way to approach those patients, to see if they really, the things in Brazil really follow the same pattern, the same pathway as the African Americans. We don't know for sure. We're just adopting this foreigner data. We don't know if our population in Brazil with black skin works in the same way. So we are just treating those patients and giving them the same explanations and same guidelines, but we are not sure if they work in the same way. So this is something that we need to work inside our community, our structure, is to have our own data. And just the same thing. The first and the most important mission for a physician, for a dermatologist, is to stand with the patient, to help him. Also, always hearing the problem, understand, putting yourself inside your patient's shoes, and understand that even the minor problem that's bothering him, like, oh, I have acne, I have pseudofolliculitis, I have a small patch of vitiligo, can be very important for him. So we need to be with the patient.